Hi and welcome to the channel Love Obstetrics and Gynecology. Today's topic of discussion is physiological changes in pregnancy. The physiological changes in pregnancy, they occur basically to support the mother and the fetus. And there are significant changes that occur in various organs. But one of the key areas is the cardiovascular system, and we'll be discussing the cardiovascular system in these next coming slides. So in this video, you'll learn about the cardiac output changes, the blood volume changes, the blood composition in pregnancy, the blood pressure dynamics, the electrical changes, and the postpartum, how the every change that has occurred in the pregnancy reverts back. The pregnancy cardiovascular changes are due basically to increase the cardiac output. The cardiac output rises by 40% in pregnancy. So if the pre-pregnancy level was from 4.5 liter per minute to 6 liter per minute, and the cardiac output rise starts very early in pregnancy and continues throughout the pregnancy till it plateaus between 24 to 30 weeks, and then it remains as such plateaus with a slight increase only. This increased cardiac output is basically for supporting the skin and breast initially, and if we talk about at term, this extra 1.5 liter is for the uterus, that is approximately 400 ml per minute. The renal, the skin, GI, breast and all the other organs, they get a increased amount of supply. So the cardiac output that has increased is dependent upon an increase in blood volume, and blood volume further depends upon two factors, that is the plasma volume and the red cell mass. The plasma volume increases significantly in comparison to the red cell mass. So the plasma volume increases by 50 to 60%, and the red cell mass is approximately 20 to 30%. So this uh, this proportional increase in the composition, or you can say the change in the composition of the blood volume, is responsible for the dilutional anemia in the pregnancy. And the physiological role or importance of that increased blood volume in pregnancy is basically, first, it helps to increase the cardiac output, and as the cardiac output increases, so as the uteroplacental blood flow. The increased uteroplacental blood flow means a lot of blood will be going to the fetus. That is important for the fetal development. And also, if we talk about when the patient goes in labor later on in pregnancy or in labor and she delivers, there will be a blood loss, which is approximately 500 ml, and that blood loss is basically going to be a diluted blood loss. So it helps in coping up with the anemia. This increased blood volume is under the hormonal influence. It starts very early in pregnancy under the effect of HCG. And later on, the role of that has been started with the HCG for the retention of water or electrolytes, that is carried on by the estrogen, and also supported by the progesterone. Progesterone is a pregnancy hormone, and it promotes the sodium retention and increases the blood vessels elasticities. So it increases the blood volume, all these hormones. There are also various changes in the blood composition. Some of the factors increase while the others decrease, and there is no change in others. So talking about the total WBC count, it increases so as the neutrophils increase. And talking about the lymphocytes, they do not increase, so there is no change in the lymphocytes. Now coming on to RBCs and hemoglobin. The RBC cell as such increase, but in comparison to the dilution that happens, so with the effect of that, the total red cell count decreases, the hemoglobin decreases, the pad cell volume decrease, and the hematocrit decrease. The only thing that does not change in this is our mean cell hemoglobin concentration. So there is no change in that. The ESR increases, which is basically due to an increase in fibrinogens. The pregnancy is a hypercoagulable state, and basically it inhibits the fibrinolysis. Hence the ESR increases. And rest of the things you can take on the slide. Talking about the coagulation factors. The coagulation factor 7, 8, 10 and fibrinogen, they all increase. And there is no change in factor 11 and 13, and there is no change in activated partial thromboplastin time. The increased cardiac output, that is by 40%, is basically dependent upon stroke volume and the heart rate, and also the peripheral vascular resistance. So the stroke volume is the amount of blood that is ejected with each heart's contraction. And the stroke volume is dependent basically upon the increase in the blood volume, which was by the plasma volume and the red cell mass. So as they increase, so is our stroke volume increasing. There is also an increase in heart rate by approximately 10%. The peripheral vascular resistance decreases. This is due to the effect or the relaxant effect of progesterone, but also contributed by other factors such as the nitric oxide, the prostaglandin I2, and a decrease in level of asymmetric dimethylarginine, which is an inhibitor of nitric oxide. So there is a decrease in that. Talking about the blood pressure dynamics. See, in early pregnancy, there is a fall in blood pressure. There is a fall in systolic blood pressure by 5 mm mercury and in the diastolic by 10 mm mercury. And in mid-pregnancy somewhere, the blood pressure tries to be as normal to the pre-pregnancy level, but still there will be a fall by approximately 5%. And later on in pregnancy towards term, you can say the blood pressure rises or comes back to the normal pre-pregnancy level, or even rises by approximately 5%. Now let's talk about supine hypertensive syndrome. See, it is position related. If a woman lies on her back, so in that case, the gravid uterus is compressing the vena cava and hence decreasing the venous return from the lower body to the heart. And that will lead to a decreased cardiac output to the rest of the body, and especially to the uteroplacental blood flow that decreases. And as that blood flow decreases, the fetus receives less of the blood and may go to a fetal distress. So we advise the pregnant woman to rest in a left lateral position rather than a supine position. Now let's talk about some electrical changes or the ECG changes that occur. So in pregnancy, as the pregnancy progresses, the uterus enlarges. The uterus is going to occupy all of the abdomen and is pushing the diaphragm upwards. And by that diaphragm movement, or by the pressure of that gravid uterus, the diaphragm moves up and the heart as such gets pushed up and gets deviated towards the left side. So that causes a left axis deviation of approximately 15 degrees, and the apical beat also shifts. There will be a faster heart rate that we've already talked about. So in the ECG also you'll see a faster heart rate, and a few waves such as inverted T wave may be seen in the lead 3 and a Q wave may be seen in the leads 3 and AVF. The cardiac structural changes occur in pregnancy as it has to increase the cardiac output. So the ventricular hypertrophy and dilatation, both of that occur, and this is basically to accumulate the increased blood volume that has occurred. So talking briefly about the cardiac changes that are specifically in the labor. There is a increased cardiac output in pregnancy already. So that continues in the labor phase too, and especially in the stage 2 of labor, the cardiac output is as much as it increases by 50%. The heart rate, talking about the heart rate during the uterine contractions that occur in the first stage of labor, that is from the onset of labor to the full dilatation of the cervix, the heart rate, especially in the contraction, it increases by 40 to 50%. And the blood pressure, the systolic blood pressure as well as the diastolic blood pressure, they both rise during the contractions. The systolic increases by 15 to 25% and the diastolic by 10 to 15%. And in the stage 2, that is from the full dilatation of the cervix to the delivery of the baby, the plasma volume is markedly increased and it rises by approximately 50%. So after the delivery of the baby, the postpartum changes, in immediate early postpartum changes we talk about, the cardiac output immediately rises even more significantly to approximately 60 to 80%. And then there is a rapid decrease in right starting from the first hour of the postpartum period. The heart rate, it decreases by 5 to 10% and then it continues to decrease until it normalizes by 6 weeks. The blood pressure may rise by 5 to 10% within the first 48 hours. This is included due to the fluid shifts that occur, and the plasma volume rapidly rises. 500 ml approximately increases due to the autotransfusion. That is basically the uterus contracts and it pushes out all of the blood that was in that gravid uterus to the normal circulation. So that is our autotransfusion. Due to that, the plasma volume greatly expands. Now talking about the late postpartum changes, in the next coming 6 weeks, the most of these changes, that is in the cardiac output, the heart rate, the blood pressure, the blood plasma volume, they be tend to get to a pre-pregnancy level. When talking about the structural changes that occur, that have occurred, such as the hypertrophy, the dilatation, these changes take some time. They can take from 3 to 6 months or even up to a year to get back to that pre-pregnancy level. So all these pregnancy changes, they are reflected as signs and symptoms in your pregnant woman. So some symptoms such as breathlessness, that may be present but only on a heavy exertion. So in case your patient is having exertion on rest or on mild exertion, that is pathological. Palpitations can be there, but they will be brief and self-limiting. Chest pain in pregnancy, physiologically it can be it can be more of a epigastric pain, which is reflux related and can be treated by simple medication. Syncope, that is dizziness, episodes can occur if she stands for a longer period of time or she is dehydrated. And mild fatigue is definitely there in pregnancy. The signs that we have to look for is that we have to subsequently monitor on every antenatal visit, basically the blood pressure, the systolic blood pressure should be somewhere between 120 to 139 mm of mercury, basically less than 140 mm of mercury. Otherwise the patient will have a gestational hypertension or some kind of other cardiac disease. Also the heart rate, in pregnancy it increases by 10%, but still it should be less than 90 beats per minute. The oxygen saturation should remain more than 97%. So these are all the pregnancy changes, all the pregnancy physiological changes, how they are reflected as signs and symptoms. So if you like my video, please do like, subscribe and share the channel Love Obstetrics and Gynecology. Thanks for watching.